So we are in the home stretch of the cardiology module. We're at the point where we're going to talk about arrhythmias. And I want to kind of set the stage for what we're going to be discussing related to arrhythmias over the next few days by talking about some of the basic science, some of the basic pharmacology. What we want to do is to provide a review of basic cardiac electrophysiology, discuss some of the different mechanisms of action for the cardiac arrhythmias, and then review the pharmacologic action of the agents that you're going to use to try to treat those. So early on in the series, one of the things that we said when you're looking at CK, and there was MM, and it stood for mega muscle, right? So rhabdomyolysis, you'd have increases in CK, and most of it would be the MM fraction. If you have a stroke, you'd have increases in CK, but you'd have an elevation in the VV fraction. And then I said, when it comes to the heart, they have the MB fraction. And that part of the work of the heart is like a muscle where it is pumping, but the other is kind of like a brain, in that the heart has the ability to be able to initiate its own beat and be able to propagate an electrical impulse throughout the heart. A lot of the beats, at least in the normal heart, are going to start right here within the sinoatrial node, or the SA node. But that doesn't mean that if I went in and I eliminated your SA node, that you would not be able to generate a heartbeat. Something else would take over as the pacemaker. Something else that has a rate of automaticity that's a little bit slower would end up taking over. Another very famous node is the AV node. We've already talked about the AV node being something that when an atrial beat will come to it, will hold on to the beat for a period of time before letting the beat go down through and going down specialized conduction tissue. In this case, the two bundle branch. So when the SA node releases its beat, there's actually specialized conduction tissue that will take it from here over to the other side of the heart. That's called Bachman's bundle. So for all intents and purposes, the atria will depolarize starting at the top and going down toward the ventricles. That's going to be viewed here as this P wave. So what the P wave is actually measuring, it's actually measuring the velocity of atrial tissue that's being depolarized per unit time. So when the SA node is just starting to shoot off its impulse, it goes through Bachman's bundle, and then only a little bit of atria is being depolarized per unit time. It's just getting started. And then a greater and greater velocity of depolarization per unit time. You start to go up here on the P wave until you get to the point where you have the maximum velocity. But then you start to run out of atrial tissue that has not yet been depolarized. And the P wave will come back down to what is here, which is the isoelectric. So when the SA node shoots off its beat, there's also specialized conduction tissue that brings it immediately to the AV node. But the AV node doesn't let it go through right away. It holds on to it for a period of time. And that period of time is your PR interval. Right? And we talked about negative dromotropic drugs. Drugs that can prolong the PR interval. Digoxin. beta blockers, non-dihydropyridine calcium channel blockers, prolonging the PR interval. When the AV node does release the beat down into the ventricle, you can see that it goes extremely fast. Almost instantly, it ends up down here at the bottom of the heart. And then the wave of depolarization starts going up in this direction, up to the top. So you see that the atria start depolarizing at the top, going down, so that when it contracts starting at the top and squeezing blood down into the bottom of the heart. In the ventricle, the depolarization going into the regular ventricular myocardial cell starts at the bottom and goes up, so the contraction starts at the bottom and goes up. That's very good for efficiency. As you get ventricular depolarization, you have this QRS complex. And then there's a period of time before the T wave, which is ventricular repolarization, ends up occurring. So there's a lot of different ion channels, co-transporters, and active transporters inside a myocyte. And what they do is they stop positively charged ions from being able to move freely through those cells. And the heart cells do something that is very interesting in that they'll have a very high concentration of potassium inside the cell. And they'll have a higher concentration of sodium outside the cell. And they turn on active pumps in order to be able to make this happen. So ions can pass through a specific channel only at certain times. The channel is gated. If the channel's open for a longer period of time, more ions can end up moving through. If it's open for a shorter period of time, fewer ions can move through. Now, what determines whether the channels are open or how many channels end up getting open? The voltage across the membrane determines what fraction of the channels are open at a given time. This is called voltage-sensitive channel. So in effect, what the cells have done is they've created a differential concentration of ions from inside to outside the cell. When a net voltage is hit, the channels will open, and then just based on diffusion, the ions that can fit through that channel are going to go through that channel and try to even out the concentration of ions inside and outside the cell. That's just the law of passive diffusion. So here's the sodium channel. And it starts out closed. You end up hitting a certain voltage, and the channel's open. And when the channel's open, because you have more sodium outside the cell than inside the cell, sodium rushes into the cell through the channel in order to try to normalize the concentration from outside to inside the cell. If you left the channels open forever, you have the same concentration of sodium inside and outside the cell. But it doesn't stay open forever. Here you have an inactivation gate, and the inactivation gate slams shut shortly after it opens. So you only get a portion of the sodium that was outside the cell in the interstitial fluid to be able to rush into the cell. Then over the course of time, the first part of the channel, what they call the activation gate, will close up again. The inactivation gate will open, okay, and then the channel is ready to be reused. So you can see that in a normal resting state, sodium cannot permeate. When the activation gate opens, sodium goes into the cell, and then the inactivation gate slams shut, preventing additional sodium from entering the cell. There's also potassium channels. And with potassium, there's a higher concentration inside the cell than there is outside the cell. So when these same types of channels open, potassium rushes out of the cell. They call the potassium channels that we're most interested in IK channels, inward rectifier potassium channels. The two that I want you to know is IKR, which is the rapid component of the inward rectifier potassium channel, and IKS, which would be the slow component of the inward rectifier potassium channel. Okay? So capital I with an Na would be your sodium channel. Capital I with a smaller k would be your inward rectifier potassium channel. You don't need to know Nernst equation. So here's a pacemaker cell. In a pacemaker cell, sodium is not a big player. The big player is that there is a channel that's leaking and leaks calcium into a pacemaker cell at a set rate. At a certain point, the slow leak ends, the channels will open, and you'll get a rush of positively charged ions, or calcium in this case, into the cell. This initiates a cascade where non-pacemaker cells will also start their depolarization. It's going to look different, but it's initiated by what's happening here in the pacemaker cell. And then the potassium channels are going to open, and you can see that the membrane potential is going to start going back down as positively charged ions start to leave the cell. Okay? So we had an influx originally of positively charged ions. And now we have an efflux of positively charged ions, reestablishing a normal potential. But when we get to this phase right here, even though the charge has been normalized, the concentrations of calcium and potassium inside and outside the cell are not normalized. They have to turn on a pump to be able to pump the calcium back out and to pump the sodium back in. So according to the charge, everything has been normalized, but according to the concentrations, things haven't been normalized. That's an important concept to talk about over the course of the lecture today. Here's a ventricular myocyte. It's not a pacemaker cell. So what do you see here? What you see is that there's very, very little change during phase 4, or the resting phase. Here, the cell gets hit by a depolarization stimuli from an adjacent cell. The sodium channels in response will open. Because there's a lot more sodium outside the cell than inside the cell, based on the laws of passive diffusion, sodium is going to rush into the cell. The net charge is going to shoot up from being negatively charged to being positively charged. That's what you see here in blue. You can see that sodium is coming into the cell through fast sodium channels, INAF. But then there's also INAS channels that will slowly allow sodium to continue to come into the cell over phase 2 and phase 3. Calcium also gets into the mix. And there's 2 types of calcium channel. There's the T-type, which is right here. You can see that it's relatively short-lived and allows calcium to come into the cell. There's also the L-type, and it allows calcium to come into the cell over the course of phases 1, 2, and 3. So what drives phase 0? The fast sodium channel. What kind of things are leaking positively charged ions into the cell through phases 1, 2, and 3? Sodium and calcium. Okay? So you can see that here in phase 0, there's very little that's trying to counteract this rush of positive ions into the cell. But when we get here into phases 1, 2, and 3, we start to have potassium channels that will open, allowing potassium to rush out of the cell. So here in phase 2, the plateau phase, you have ions rushing into the cell that are positively charged, and you have ions that are rushing out of the cells that are positively charged. That's why you have a plateau. You're maintaining your net overall charge, but you're doing it based on an exchange of positive for negative ions, just based on the law of passive diffusion. But let's look at IKR, and you can see that it starts out when it gets going, and then it's relatively steady through phase 3. And then we'll look at IKS, or the slow component of the rectifier potassium channel, and you can see that it gets greater and greater over the course of time, peaking around phase 3. Right? And these are the ones that I want you to focus on. Your non-dihydropurity and calcium channel blockers are L-type calcium channel blockers. Many of your antiarrhythmic drugs, especially your class 3 antiarrhythmic drugs and your class 1As, are going to work on potassium channels, either IKR or IKS. Your sodium channel blockers are going to work on sodium channels. So eventually, when you hit phase 3, there are more positively charged ions leaving the cell. There's more potassium leaving the cell than there is sodium and calcium coming into the cell. So you can see that different types of cells on a monophasic action potential recording are going to look a little different. The pacemaker cells look different from the regular cells. But the atrial cells look very similar to the ventricular cells. It's just that the pacemaker cells are looking different. So what is a monophasic action potential? If you take a catheter and you put it into the subclavian vein, you put it down into the superior vena cava, you push it down into the right atrium, down into the right ventricle, and it pushes against the right ventricle, you'll get a monophasic action potential recording of electrical charge that would look like this. And that's what we just showed on the last slide. It's looking at charge. So that's different than an EKG segment, where the EKG segment is looking at the velocity of depolarization per unit time. So you can see that phase 1 or phase 0 into phase 1, okay? Phase 0 into phase 1 looks very much like the beginning of the QRS complex. But you can see that from the peak down to the end, okay, you get this rapid decline here on the EKG, where you don't get that decline here. Why? Because one is looking at the net charge, the other is looking at the velocity of depolarization. On the EKG here, by the end of the QRS complex, all of the ventricular myocardium has been depolarized. But there's still a lot more positive ions in the cell than there was normally. So what does this T wave correspond to? Well, this is ventricular repolarization. And when does it occur? It occurs during phase 3 on the monophasic action potential recording. This is when you start having more positive ions leaving the cell than you have coming into the cell. The net charge starts to go back down towards normal. But keep in mind that even at the end of the T wave, even at the end of phase 3 of the monophasic action potential recording, when your net charge is back down to where it was at baseline, it doesn't mean that that cell is normal. It has a lot more sodium inside the cell. It has a lot more calcium inside the cell than it did normally. It's got a lot more potassium outside the cell than it did normally. The body still has to do that last phase, which is pumping potassium back into the cell in exchange for calcium and sodium. So the one thing we haven't talked about is, where does atrial repolarization occur? And how come it's not here on the EKG? The reason why is that it occurs within the first half of the QRS complex, and you can't see it. So the atria actually does repolarize just like the ventricles do, but it happens during the first half of the QRS complex, and it's hidden by the QRS complex. Phase 0 is the resting state. It's just sitting around waiting for a wave of depolarization to hit it. When it does, it transitions from phase 4 up to phase 0. Sodium channels open. Sodium ions rush into the cell, causing the membrane potential to become less negative. In phase 1, there's some slight repolarization caused by the outflow of potassium ions. Remember, sodium is still rushing into the cell, but in this phase, there's more potassium leaving than there is sodium coming in at that time. Then you hit the plateau phase. During the plateau phase, sodium and calcium are coming into the cell, potassium is leaving the cell, but the net charge, because of the number of positive ions going in and out, are balanced. You have this plateau phase. In phase 3, more positive ions are leaving than are coming in, so the net charge is going back down toward baseline. And then here at the beginning of phase 4, sodium and calcium are being pumped out, potassium is being pumped back in. Refractory periods. Let's do a little experiment, okay? Let's say that you are the left ventricle. So the SA node shoots off a beat. The beat goes here through the atrium, starting over here and coming as a wave of depolarization in this direction. It hits the AV node. The AV node is holding on to it. The atria contract. It starts contracting in this direction because the wave of depolarization started there, coming in this direction. The vector of depolarization is an arrow pointing straight down here. Going through the mitral valve, the blood ends up going. The AV node releases the beat. And when it releases the beat, it goes down the two bundle branches. One of the bundle branches brings the wave of depolarization all the way down through to the apex of the heart, which is the very end, the bottom of the heart. So the action in the ventricle starts here. The wave of depolarization hits this row. This row becomes depolarized. Okay? So at this fraction of time, all of these cells are waiting for a new beat to come in. They're perfectly ready to accept it. They have a normal concentration of potassium inside the cell. They have a normal concentration of sodium outside the cell. Normal concentration of calcium either stored in a packet inside the cell or outside the cell. A fraction of a second later, the wave of depolarization moves from this row to this row. You guys all depolarized. But this row is now effectively refractory to accepting another beat. So I can shock these people with as much electricity as I want to. Depolarize. Depolarize. She's not depolarizing. Look at it. There's no depolarization occurring here. She's effectively refractory. A fraction of a second later, the wave of depolarization has moved to this row. This row is now effectively refractory. Okay, I'm zapping the people in this row. No depolarization is happening. This row right here is now vulnerable. You've all felt vulnerable sometimes in our life. And after every time that a cell contracts, there's a period of vulnerability. So why are these people vulnerable? Well, their electric charge is normalized. They should be able to accept a new beat, but the problem is they have a lot more sodium inside their cell than they did normally. They got a lot more potassium outside their cells. So if the channel's open now, and sodium tries to come in, the gradient or the difference in sodium and potassium concentrations is not as great as it should be. You're not going to get the same rushing in of ions. The cells don't really know what to do if that happens. So what they do is they freak out. Okay? When these cells freak out, it initiates arrhythmia. If it happens in the atria, you'll get atrial fibrillation. If it happens in the ventricles, you'll get ventricular fibrillation. But a That very rarely happens. Why? Because in order for it to happen, the wave of depolarization that's moving in this direction would have to jump up, would have to go backwards over this zone that's effectively refractory, this safety buffer, and be able to hit this zone here. So the body has a mechanism in place to try to protect the cells that are only relatively refractory from being hit by the wave of depolarization. The vector of depolarization goes in this direction, starting in the back and then moving forward. And when it hits this row, a fraction of a second later, it gets abolished by the effective refractory period. So you don't get a wave of depolarization that comes this way and then goes back that way, because right behind the depolarization wave is an area that's effectively refractory, will not accept electrical stimuli. Okay? So refractory periods are incredibly important. The effective refractory period is a buffer zone of safety. The relative refractory period is that spot when those cells are very vulnerable to initiating arrhythmia. And when does it occur? In the atria, it occurs within the first part of the QRS complex when it is repolarizing. In the ventricle, it occurs from the peak of the T wave down to the end of the T wave is when they are relatively refractory or vulnerable. G peak to T end, they call it. Let's talk about some mechanisms of cardiac arrhythmia. Any abnormality in the electrical rhythm is known as an arrhythmia. Some people call them dysrhythmias. You could have a bradycardia or a bradyarrhythmia where you have a slow rhythm. You could have a tachycardia where you have an abnormally fast rhythm. If they use the term supraventricular, it means that it involves the atrium or the AV node. If they call something ventricular, it goes from the His-Purkinje system or the ventricle. Disorders of heart rhythm result from alterations in one of two things, either impulse formation or impulse conduction. We'll talk about each of those separately. So at this point, just to make sure that you're oriented, what you have to know. Okay? What you have to know is you have to know that in a pacemaker cell, there's a slow, chronic leak of calcium into the cell that when it hits a threshold, will lead to a wide-scale opening of calcium channels and initiation of a beat. That will be abolished by turning on potassium channels and having potassium rush out of the cell. Pacemaker cells help to initiate beats inside the heart. Regular ventricular myocardial cells, you have to know that slide that has phase 4, 1, 2, and 3, and you need to know that that's caused by and large by sodium rushing into the cell in phase 0. You need to know that phases 1 and 2, there's a relative balance of sodium and calcium coming into the cell and potassium going out of the cell. In phase 3, you have more potassium leaving than you have sodium and calcium coming in, and that helps to reestablish a normal concentration or a normal charge. But that in phase 3, even though you have normalized the charge by the end of phase 3, this is actually the vulnerable period because the concentrations of sodium, potassium, and calcium have not yet been normalized. That happens early on in phase 4. That's what you need to know. All of those slides have been summarized here. This is what I would ask you questions about. Okay? Impulse formation. Arrhythmias may arise from altered impulse formation. There's three main abnormalities of impulse initiation or formation that lead to arrhythmia. Altered automaticity, abnormal automaticity, or triggered activity. What is automaticity? Well, that's what happens inside, normally, pacemaker cells. The ability to automatically generate a depolarization. Let's talk about what this means. What about sinus tachycardia? Sinus tachycardia is when you get an SA nodal firing rate that's greater than 100 depolarizations per minute. So you could get it if you had sympathetic stimulation through beta-1 adrenergic receptors. Heck, it's Tuesday. Let's do some crystal meth. Maybe you get sinus tachycardia. Okay. Bath salts, MDMA, cocaine, or pharmacologic drugs, epinephrine, norepinephrine, dobutamine, stimulate beta-1 adrenergic receptors. You could also get sinus tachycardia if you block the parasympathetic nervous system with anticholinergic drugs, like your phenothiazine, antipsychotics, your tricyclic antidepressants, or anticholinergic that people may use for Parkinson's disease. Okay. So I want you to know this. Sinus bradycardia, a heart rate of less than 60. It doesn't mean that it's horrible if your heart rate's less than 60. Remember that in people who had angina pectoris, people with a myocardial infarction, when you were using beta blocker therapy, you either wanted to achieve target doses or you wanted to achieve a heart rate between 50 and 60 beats per minute. You effectively want people to be slightly sinus bradycardic. An SA nodal firing rate less than 60 depolarizations per minute. Sinus bradycardia. How can you get that? Well, you can get it by increasing the parasympathetic nervous system. Remember, that was one of the ways that digoxin worked. It increased vagal stimulation to decrease heart rate. Or you can decrease sympathetic stimulation. The parasympathetic nervous system is a major controller of heart rate at rest. The average heart beats a little bit slower than it would if you ripped it out of your chest and stuck it in fluid that had everything that it needs to continue beating, and actually have that animal model. Okay? So if you take somebody's heart out of their chest very quickly, and then you bathe it in a solution that has all of the things that it needs to continue to live, the heart will continue to beat outside of the body. But it'll beat faster than it would normally, because you don't have the effects of the parasympathetic nervous system hitting it at rest. Cholinergic or parasympathetic stimulation via the vagus nerve acts on the SA node to reduce the probability of pacemaker channel being give a reduced heart rate. So beta blocking drugs, non-dihydropyridine calcium channel blockers, or acetylcholine can cause sinus bradycardia. You don't need to know anything about these curves. Just know that stimulating the sympathetic nervous system or taking away the parasympathetic nervous system makes things go faster. Makes the SA nodal firing rate faster. Less sympathetic stimulation or more parasympathetic stimulation will make your pacemaker cells go slower. Here's a bunch of the different arrhythmias, and here's some common features of those different arrhythmias. We're going to talk about some of these and how they come about. So here's your pacemaker cell. That's your SA node. In atrial flutter, for whatever reason, there is something else. There is some other cell that decided it doesn't want to take any crap from the SA node. It wants to pace the atrium. So it starts shooting off depolarization, feeds itself. But it's doing it at a faster rate than normal SA nodal automaticity. So what you see is you'll see multiple P waves before each QRS complex instead of just a single one. All of them will look the same. The morphology will be the same. And they'll be the same because they're starting in the same place and they're propagating in the same way through the atria. So they're going to look the same on the EKG. It's going to have what they call a sawtooth appearance. Not all of these atrial depolarizations are going to make it into the ventricle. The AV node is going to filter some of them out. So look at the differential in ventricular rate. Ventricular contour is going to be normal. You're going to have narrow QRS complexes because it's being propagated from the AV node down through the ventricles in a completely normal way. But atrial flutter, you could either have normal or you could have increased ventricular rate. Let's look at PSVT. So here's your AV node. But right below the AV node in the AV bundle, in people with PSVT, that decides like it's going to take over and turn into a pacemaker. So it's going to be sending impulses down into the ventricles a lot faster than the impulses that it's receiving coming from the atrium. So even though the atrial rhythm is regular, you see narrow QRS complexes all in rapid succession. That's PSVT. Why are they still narrow? Because they're going down the two bundle branches and then they're coming up regularly. So there's nothing slowing down the rate of depolarization inside the ventricle. Here you can see the ventricular rate is elevated. You can see the atrial rate is normal. Atrial rhythm is normal, ventricular rhythm is normal, and the ventricular contour is normal. Now let's talk about ventricular tachycardia. In ventricular tachycardia, the ectopic foci, or the reentrance circuit, is located inside the ventricle. And it's not located within the normal bundle branches or Purkinje fibers. So when this wave of depolarization shoots off, regardless of how fast it shoots off, the wave of depolarization starts going like this. Spreads out in this direction. So it takes a lot longer to depolarize the ventricle than it did regularly. So think about this. In a normal segment, it looks like, let's just assume that there's two different people, and the two different people need to run to either side to depolarize. Versus having both of the people starting here and having to have them run all the way over to the other side. It's going to take twice as long to get over there. What that means on the EKG with ventricular tachycardia is that the QRS complexes are going to be wide. They're going to be wider than normal. Why? Because the amount of time that it's depolarizing is a lot faster. So ventricular tachycardia, the atrial rate is normal, even though you really can't see what's going on in the atria. The P waves get lost in what's happening with the ventricular. The ventricular rate can be very, very fast. Ventricular rhythm is irregular because of the wide QRS complex. However, ventricular tachycardia is monomorphic in that it has one different shape. The QRS length is going to be the same. The shape is going to be the same, repeated over and over again over the course of time. Monomorphic. In torsades, the same thing happens with one exception. In torsades, the arrhythmia begins to propagate in this direction rather than in that direction. That seems kind of complicated. Let's walk through it and try to talk about it. So here's your ventricle. Okay, here's your left ventricle. You have tissue here. It forms this cup that holds the blood. The walls here and here are relatively thin, okay, but when you go in this up or down direction, you go through a lot more ventricular myocardium than when you're going in this direction. So in torsades, the ventricular arrhythmia starts in this direction. So even though you have a wide QRS complex, the amplitude, the height, is lower. In torsades, the orientation of the arrhythmia starts in this direction, but it starts to change. It starts to move in this direction. And then it moves in this direction. And then it moves in that direction. And as it's moving, the amplitude gets greater and greater, up to a maximum height, and then the amplitude gets lower and lower. And then it gets bigger and bigger, and then it gets smaller and smaller in a repeating pattern. The amplitude changes because the orientation moves from the side to up and down, and it rotates back and forth. We'll talk about why that is a little bit later and how that ends up occurring. So it's not monomorphic. It has many shapes, all different amplitudes. It's a polymorphic ventricular tachycardia. Torsades is a polymorphic ventricular tachycardia. And then we have atrial fibrillation and ventricular fibrillation. In atrial and ventricular fibrillation, what's happened is exactly what we discussed when we did this mental experiment. One of these ectopic foci, or reentrant circuits, ended up hitting a section of the myocardium, either in the atria or the ventricle, in the vulnerable period, causing that entire atria or entire ventricle to freak out. And when it freaks out, what happens is that in the atria, multiple pacemakers all try to take over at the same time. If it happens in the ventricle, multiple pacemakers all jump up and try to take over what's happening in the ventricle. The problem with this fiefdom, where there are tons of bosses, is that the wave of depolarization from any one of them will start to move and will hit a wave coming from another depolarization, and they'll cancel each other out. So there's no contraction in the atria. There's no contraction in the ventricle. They just quiver. And no blood moves. Now, in atrial fibrillation, if your atria quiver just based on gravity, you can get some blood to go down in your ventricles, so you can live. If you have ventricular fibrillation, that's cardiac arrest, and you would have no pulse. Okay? So only undulation. Okay. Why does fibrillation occur? It occurs due to vulnerable periods. Cells can be in one of those four phases. One of the phases is when they are only relatively refractory for what we call the vulnerable period. When you force vulnerable cells to depolarize, they don't have normal amounts of sodium outside the cell. They don't have normal amounts of potassium inside the cell. They get a very different response when they open their channels than what they usually get. The cells don't know how to deal with it. They freak out. All the cells try to turn into pacemakers. And you can't have 20,000 pacemakers and have a uniform or coordinated contraction. So you get fibrillation. But we said that there's this protective zone, or the effective refractory period, that stops waves of depolarization from being able to jump backwards and be able to stimulate waves that are in the vulnerable period. And that's true. But you can have an anatomical setup that allows for fibrillation to occur. That anatomical setup is scar tissue. If you have electrically inactive tissue or scar tissue in the atria or the ventricle, you can fractionate the waves of depolarization into wavelets, causing reentrant circuits. Let's see what that looks like. You didn't eat right. You had a bacon bowl every morning for breakfast. You had a myocardial infarction. So now you have areas here that's dead. Now normally, when you have your impulses, your wave of depolarization, the vector of depolarization, is going to be moving in the upward direction. But what happens when it hits this area where there are dead cells? Okay, the wave of depolarization is shooting in this direction. Every person who's here is a living person. Every chair that is not occupied, okay, is a dead cell. Students who are supposed to be sitting there are dead to me. But let's look at the wave of depolarization as it goes through. It should just be going in this direction. But what happens is the wave of depolarization comes into this area, and it can't depolarize here. So now we have two waves of depolarization. And then what happens when it gets over here? Who's going to depolarize? This person. Okay? Is it going to be you? You got somebody dead behind you, right? So are you going to shoot your depolarization wave over there? Or are you going to shoot your depolarization wave over here? And keep in mind that in the ventricular myocardium, there's going to be classrooms of people on top of you and below you in three-dimensional space. Are you going to depolarize somebody below you? Some people end up getting walled off. Okay, so look at this. Look at the guy with the gray shirt here. Who's going to depolarize that guy? You know who's going to depolarize it? The wave of depolarization is going to go down in this direction. The lady in the red coat is going to depolarize this person. You're going to depolarize that person. Now the wave is actually going to be going sideways. The guy with the checkered shirt is going to depolarize the guy with the gray shirt. The wave of depolarization, this wavelet, is actually going to be going in this direction, while other cells are going in that direction. Okay? Well, let's say that this guy in the gray shirt gets depolarized. And then he comes over and depolarizes the lady in the red coat again when she's in the vulnerable period. What is she going to do? She's going to freak out. Wah! And then when that happens, everyone's like, I'm the boss, I'm the boss. Everyone wants to be the boss, and you have fibrillation. Okay? So you can see that in a normal heart, you don't have the risk of fibrillation because you have the vulnerable period that will protect you. But if you start adding inactive or scar tissue to the mix, you can have something that's much more complex. So usually there's an anatomical setup for arrhythmias to occur. And then there's also triggers. Triggers are things that make atrial or ventricular cells irritable or supercharged. Body revving substances are one of the triggers. These are things that you have to know. Right? You have to know what increases the risk of arrhythmias. There's an anatomical setup for arrhythmias, and then there are triggers for arrhythmias. Body revving substances, thyroid hormone, and catecholamines are body revving substances that can increase the risk of arrhythmias. Ischemia can increase the risk of arrhythmias because remember, ischemic tissue goes into a hibernatory state, so it depolarizes slower than other zones. So the wave of depolarization is coming, but over here we've shut off blood flow through one of the coronary arteries, so you guys aren't getting a lot of blood. So you're like, oh, screw that, I'm not going to depolarize regular, I'll do it whenever I want to. So the wave of depolarization shoots by here. Okay? And you guys are like, yeah, alright, I'll depolarize you, and then you depolarize this person, and then you depolarize over there. But now you can see that because you're going so much slower than this zone, your wave of depolarization may be moving along with somebody else's wave that is relatively refractory or vulnerable. And what happens if you stimulate one of those people? They freak out and fibrillation enters. Okay. Hypokalemia or hypomagnesemia. Cells don't like that. Makes them more prone to having arrhythmia. Atria or ventricular stretch. So your patients who have heart failure, when you're stretching the atria, when you're stretching the ventricles, they don't like that. They become irritable. They're more likely to start and become an ectopic foci. And then inflammation. Inflammation either of the myocardium itself or the pericardial sac that sits on top of the heart and that separates the heart from the lungs. If they get irritable, that's a trigger for fibrillation. This is the slide you got to know. There are lots of things that can all come into doing it. There's the anatomical setup, and then there are triggers. That slide you have to know. This is kind of all put together so that you can see what it is that you want. This just shows you the vectors of depolarization, how in the atria, the vector of depolarization goes down in this direction. From the ventricle, it goes up in this direction. Okay? And then you can see that when you have scar tissue, instead of having just one vector of depolarization going up each of the two ventricles, you end up with multiple wavelets going in all different directions, increasing the chances that you will hit in the vulnerable period. When are the vulnerable periods? You've got to know that the vulnerable period inside the atria is in the first half of the QRS complex. That's the vulnerable period in the atria. The vulnerable period in the ventricle happens from the T peak to the T end. If you take a pacemaker and you stick that pacemaker inside the atria, you can cause atrial fibrillation to occur. Here is an unfortunate sheep. And you can see that here's the QRS complex, here's the QRS complex. When the QRS complex was just starting right here, somebody hit the red button. And when they hit the red button, it caused burst pacing through the pacemaker, and it resulted in atrial fibrillation. Now you notice, though, that the atrial fibrillation didn't occur forever. The body has normal mechanisms to prevent continued propagation of arrhythmia. So it corrected itself, and it went back to normal rhythm. But 5 more times that day, 6 times every day, somebody hit the red button and caused atrial fibrillation. And look what happened 24 hours later. The average duration of atrial fibrillation was not 5 seconds, but was now 20 seconds. And they continue to push the red button 6 times every day for 2 weeks. And you can see that now, even though you only had bursts, the propagation was much longer. And actually, in this case, in this sheep, lasted for a 24-hour period of time. So that shows that if you have this anatomical setup and you have these triggers, that the more often you have an arrhythmogenic event, a fibrillatory event, the more or the longer subsequent episodes are going to last. So we talked about the setup inside the ventricle, scar tissue from either heart failure or scar tissue from a myocardial infarction or some anatomical anomaly that leads to this wavelet formation. In the atria, it's a little bit different. Most people who develop the arrhythmia atrial fibrillation, the atrial fibrillation initiates inside the pulmonary vein. Why does it initiate inside the pulmonary vein? That's what we're going to talk about in this slide, and then we're going to take a break. So I titled this slide, "What do I want to be when I grow up?" So let's say that you guys wanted to build a Dr. White. Okay. So you think that the box would arrive, it would be full of Dr. White parts. You'd start building maybe the skeleton first, right? And then you'd put other things in and around or create a Dr. White. That's not how it happened. Heavy drinking was involved. Poor choices were made. And I was a single cell. And then I started to divide, and then I was 2 cells, and then 4, and then I was 8, then I was 16. And I kept dividing, and I was this giant clump of cells. And at a certain level, the cells started to have to ask themselves, what do I want to be when I grow up? So in the area of my body where all the other cells were deciding they wanted to be bone cells, the choice was relatively clear. All right, I guess I'm going to be a bone cell. It doesn't mean, though, that if I didn't go into your bones and look at every single cell that you have in your bones, I wouldn't find an occasional liver cell, because I would. In every society, there's some radicals that don't want to do what everyone else is doing. But by and large, in the middle of a bone, almost all of the cells are bone cells. But what if you're on the border between bone and cartilage? Are you going to be bone, or are you going to be cartilage? So we think that there's bone and then there's cartilage. But the reality is that there's bonish cartilagishness in the border. And as you go further away from the bone, fewer cells made the choice to be bone, more made the choice to be cartilage. The same thing happens on the border where the pulmonary veins are bringing blood back into the left atrium. Some of the cells are deciding to be atrial cells. Some are deciding to be pulmonary vein cells. If you decide you're an atrial cell, you have the ability to contract, and you have the ability to propagate electrical impulses. If you decide that you're going to be a pulmonary vein cell, you're going to live and you're going to be there. You're not going to propagate electrical impulses. You're not going to contract. Okay. So here you have this border. Okay, blood is coming in from this direction through the pulmonary vein into the left atrium. And here you have some cells that decided that they were going to be atrial cells rather than being pulmonary vein cells. The wave of depolarization comes in. It's coming in this downward direction. Okay, and it goes by like this. But this cell also gets depolarized. It then depolarizes this cell, that depolarizes that one and that one and that one, and you can see that this person, unfortunately, has what they call a reentrant circuit. They have atrial cells inside the pulmonary veins that go out and at some point loop around, coming back into the atrium. If it comes out into the atrium during the vulnerable period, it'll start atrial fibrillation. Now, if that happens only once every couple of years, probably won't last more than 5 seconds. You never even know that you had it. Okay? But if you start stretching the pulmonary veins, if you start doing other things, and one of these cells decides that it also wants to be a pacemaker, it could shoot impulses in 2 or 3 different directions in 3-dimensional space, increasing the chances that they'll come out in the vulnerable period and cause atrial fibrillation. If the sinus node becomes suppressed, the site of impulse formation will shift to another pacemaker. So the automaticity of other pacemakers are set up so that they don't hit their threshold as fast as the SA node. So the SA node normally is the pacemaker. But if you suppress it through some mechanism or you destroy the SA node, you'll still have an impulse that will form. But that means that your depolarization rate will end up being slower. You can also make it faster. Okay? And we've talked about those things before. High catecholamine concentrations can increase automaticity of cells. Hypoxia, ischemia, electrolyte disturbances, drug toxicity can all have that same kind of effect. You don't need to know the difference between early and delayed after depolarization. Here, what you see is that in phase 3, something hit within the vulnerable period and caused an arrhythmia to occur. That's an early after depolarization. If it happened way down here in phase 3, that would be called a delayed after depolarization. It doesn't matter if you know the difference. We talked about reentry here. Okay. Scar tissue can also allow for reentry. And that's what I want you to most of the rest of what's on this slide is more detail than what I want you to This is what a reentrant circuit could look like. You can see here, this cell is not propagating an impulse in this direction, but is propagating one in that direction. The impulse travels around where it can go backwards in this direction. Okay? Setting up a reentrant circuit. In PSVT, in atrial flutter, very often this is the setup that ended up occurring. So the impulse can keep going around and around. Okay? Pacing the atria at a faster rate than the SA node has the ability to do. So you can see that ectopic foci, one cell that just turns into a rebel and starts shooting off impulses very quickly, is one way that you can take over from the SA node. The other is this reentrance circuit. And we'll stop there and come back in 5 minutes, and then we'll talk about it. We've talked about the bundle branches being the things that bring the impulse from the atria down to the ventricle. Some people have a bypass tract between the atria and the ventricle. These people have Wolff-Parkinson-White syndrome, or WPW. So in WPW, they have a bypass tract. The bypass tract on an EKG would show up looking like this. Instead of seeing a crisp upshoot of the QRS complex, you can see that it kind of has an upslurry, right? It has kind of a rounded appearance to that, and they call a delta wave. The PR interval is shorter because you start getting some ventricular depolarization through this mechanism, which ends up going pretty slowly because it's not using specialized conduction cells like the bundle branches in the Purkinje fiber. So most of it ends up getting depolarized through the normal route, but some of it ended up getting depolarized through this bypass tract route. The problem is that you now have two different waves of depolarization coming against each other, which increases the chances that you might hit something in a vulnerable period and end up with ventricular fibrillation, which is a risk that people in WPW have. The other potential risk is that you could end up having a beat that goes down the AV node, ends up coming up, and goes back through, setting up a reentrance circuit here. So Wolff-Parkinson-White, it's uncommon. 1 person out of every 1,500 people can have one of these bypass tracts. How do you treat it? If you have a patient who has WPW along with atrial fibrillation or PSVT, electrical cardioversion is a class 1 recommendation, not based on fantastic overall evidence. Okay, level of evidence C. You could also treat it with procainamide or ibutylide. Class 1 recommendation, level C. You cannot use a drug that would block the AV node. So usually for PSVT and atrial fibrillation, that's exactly what it is that you want to do. Use a negative dromotropic drug. But if they also have WPW, you have to know not to do that. Somebody comes in and they have atrial fibrillation. One of the early steps is usually to apply a negative dromotropic drug, but you want to look at the EKG to make sure they do not have a delta wave before you do. If you do, you increase the risk of ventricular fibrillation. So this is a class 3 recommendation. The level of evidence is actually pretty good at a B. Catheter ablation of the bypass tract has revolutionized things. We used to really stress WPW. We used to talk about it for a long period of time during these lectures, because a lot of people ended up having it. But now, when they find out that you have it, and it usually runs in families, they'll bring people in, they'll take a catheter, they'll burn the bypass tract, and then you don't have WPW anymore. This is what it looks like. Here's your bypass tract. They put the catheter down through the subclavian vein, into the superior vena cava, down into the the right atrium, they push it against the bypass tract, they turn on the pacemaker. If they see that it is being propagated down through here, they'll turn on the heating unit and they'll destroy the bypass tract. That's just an orientation slide. Let's talk about some antiarrhythmic drugs and what those antiarrhythmic drugs do. You have class 1 antiarrhythmic drugs, which are your sodium channel blockers. You have your class 3 antiarrhythmic drugs, which are your potassium channel blockers. And then you have drugs that will work on the SA and the AV node, beta blockers, and your calcium channel blockers. Remember, all the calcium channel blockers that we have that are FDA approved are L-type calcium channel blockers. For the class 1 antiarrhythmic drugs, we have 3 different flavors. We have the 1As, the 1Bs, and we have the 1Cs. These were given their designation based on when they came onto the market. The 1As were first, followed by the 1Bs, and then the 1Cs. The 1As cause a moderate degree of blockade of sodium channels. The 1Bs have milder blockades, and then the 1Cs have more marked blockade. These are the drugs that are the 1As, the 1Bs, and the 1Cs, and you have to know if it's a 1A, a 1B, or a 1C. So you have to know these drugs. The beta blockers all end in OLOL, okay? With the exception of propafenone. Propafenone is also a non-selective beta blocker that also happens to be a class 1C antiarrhythmic drug. It's the only one that doesn't end in OL. Here's your class 3 antiarrhythmic drugs. They are potassium channel blockers, and there's a wide variety of those drugs that you have to know also. And then the class 4 are your non-dihydropyridine calcium channel blockers, verapamil and diltiazem. What I want you to know, though, is I want you to know that the 1As, in addition to being sodium channel blockers, are also potassium channel blockers. So Dr. Chamberlain, for his rotation students, had an antiarrhythmic mnemonic to help to learn the drugs that are 1As, 1Bs, 1Cs, and 3 that you can decide to use if you would like. Or you could use my method, which is don't be a baby, just look at the list and memorize. Beta blockers, non-dihydropyridine calcium channel blockers work on the pacemaker cells, and they reduce the automaticity so that they slow down SA nodal fire. That's pretty much all you need to know there. What is it that the class 1A and the class 3 drugs do? What they do is they prolong the effective refractory period. So the class 1 and the class 3 antiarrhythmic drugs prolong the effective refractory period. That you gotta know. Now they do it in slightly different ways. Sodium channel blockade will push the effective refractory period from T peak a little down the T wave. The potassium channel blocking effects will just push the T wave further away from the QRS complex. In both cases, you've increased the effective refractory period. You just did it in a different way. Okay, some important things that you have to know. You have to know that the 1As, in addition to blocking sodium channels, also block potassium channels. So just like the class 3 antiarrhythmic drug, can increase the risk of the arrhythmia and torsades. You have to know that the class 1B antiarrhythmic drugs like lidocaine and mixilotine do not work in atrial tissue. So you can't use it to treat somebody who has atrial fibrillation or flutter because they don't work in atrial tissue. The class 1C antiarrhythmic drugs what you have to know about them is you can't use it in structural heart disease. What is structural heart disease? People who have left ventricular hypertrophy, people who have myocardial infarction, and people who have heart failure have structural heart disease. If you use a class 1C antiarrhythmic drug in those people, you'll increase the risk of monomorphic ventricular arrhythmias, and you increase their risk of death. How do they know? Because they've used them in these people in a large clinical trial called the CAST trial. People who were having myocardial infarctions and were having frequent premature ventricular complexes. They tried to suppress those with the class 1C antiarrhythmic drug, and unblinded the study. They found out it was the class 1Cs were killing patients faster, not that they were providing the benefits that they had hoped. So you cannot use the class 1Cs in structural heart disease. Okay? You don't need to know anything about this. This just shows that you're pushing the T-wave further away from the QRS complex when you're blocking the potassium channel. Specific class 3 antiarrhythmic drug, amiodarone. Amiodarone is a very interesting drug. It has 6-compartment pharmacokinetics. Nobody has worked out the pharmacokinetics of amiodarone in a way that will allow you to predict its effects based on blood concentration. The greater the dose that you administer, the greater the efficacy, also the greater the risk of adverse effects. But blood concentrations are not predictive of efficacy or toxicity. Amiodarone is a class 3 antiarrhythmic drug, but it actually has properties of all 4 antiarrhythmic von Williams classes. It has anti-adrenergic effects. It's not a beta blocker. You can use it in patients who have reversible airway disease. But it does have anti-adrenergic properties like class 2. It does block calcium channels. It does block sodium channels. It does block potassium channels. Dronedarone. Dronedarone is very similar to amiodarone, except it does not have this iodine moiety. And we're going to see later on that by not having this iodine moiety, you actually reduce the risk of adverse effects pretty significantly over amiodarone. But it's also not as effective as amiodarone. Amiodarone is the most effective antiarrhythmic drug that is on the market, but it's highly toxic to a lot of people. Even though dronedarone is classified as a class 3 antiarrhythmic drug, it also has effects of other von Williams classes as well. Dofetilide, ibutilide, sotalol, and bertilium are class 3 antiarrhythmic drugs. They work by blocking IKR. Amiodarone and dronedarone block both IKR and IKS, and because they do, they have a reduced risk of causing torsades versus these other class 3 antiarrhythmic drugs, or versus the class 1A antiarrhythmic drugs. Sotalol is a non-selective beta blocker, so you need to keep that in mind. Okay? Especially for your patients who you have reversible airway. Now we're going to talk about transmural dispersion of repolarization. The class 1As and the class 3s both block potassium channels. But the class 1As and the 3s, except for amiodarone and genetodarone, only block the IKR potassium channel. They don't block IKS. And because of that, they increase the transmural dispersion of repolarization. I'll show you a slide next that will help to put it into context. Amiodarone and genetodarone, ranolazine, the drug we talked about for angina, and pentobarbital all can prolong the QT interval, but have a lower risk of causing torsades because they block both IKR and IKS. So while the QT goes up, it does not increase the transmural dispersion of repolarization. So right here, okay, let's say we cut across the wall and we looked at it very carefully. What we would see is that there was an endocardial layer, there was a level in the middle that was the mid-myocardial layer, and there was something that was on the outside called the epicardial layer. When this wave of depolarization is going up the left ventricle, the wave of depolarization should be a single line, okay? A single line going straight across that's going in this direction. This is the wave of depolarization, followed by the effective refractory period, followed by the relative refractory period. What you see is that when you use regular class 1A or 3 antiarrhythmic drugs, these different layers have different concentrations of IKR to IKS. And if you're only blocking the IKR, it means that you have a different propagation rate in different sections of that myocardium. So look, here you have this going much faster in the mid-myocardium than you do in the epicardium. What's the risk? The risk is that this wave of depolarization within this zone is going to jump over into this zone during the vulnerable period and cause an arrhythmia. When this arrhythmia occurs, it'll be the only type of arrhythmia that ends up getting propagated in this direction, across the myocardium, rather than this direction, up and down the ventricular myocardium. So we already talked about the effect that that would have. It'll give you a lower amplitude arrhythmia. But then it'll begin to rotate like torsades does, and the amplitude will be greater and greater, and then smaller and smaller, and then greater and greater. Let's look at amiodarone, genetodarone, pentobarbital, and ranolazine. Even though it's blocking potassium channels, because it blocks both IKR and IKS, there is less transmural dispersion of repolarization. There's a lower risk that this, if it jumped over, would hit something other than the effective refractory period. Or that the endocardial, if this zone of depolarization ended up jumping over, that it would hit during the vulnerable period. So look at the regular ones again. Look at the differential that you see in how fast depolarization is occurring and the increased risk that you could hit during the vulnerable period. Take-home message: amiodarone, genetodarone, ranolazine, and pentobarbital may prolong the QTC interval, but does not increase the risk of torsades to the same extent. There's another pharmacologic concept which is called either use-dependent or reverse use-dependent. Drugs that hit the sodium channels, when we talk about their effects on the sodium channels, those effects are use-dependent. The faster the heart rate, the greater the blockade of potassium channels. Okay? Drugs hitting potassium channels exhibit reverse use dependence, which means that the slower the heart rate, the greater the blockade of potassium channels. Why is that? Drugs that block potassium channels block those potassium channels. They actually get in and interact with the channel when the channels are in their closed state. So when your heart rate is slower, you have a greater opportunity for the drug to be able to interact with that channel and inhibit it. So if you have a faster heart rate, potassium channel blockers do not work as potently as they do when the heart rate is slow. Reverse use dependent. When you're blocking a sodium channel, the faster the heart rate, the greater the degree of blockade. This is because these drugs actually block sodium channels when the channels are open. So if the channels are open more, you have a greater chance that the drug is going to be able to sit on the channel and inhibit that channel. A class 1A antiarrhythmic drug inhibits both sodium channels and potassium channels. That means that the sodium channel part is going to have use dependence. The potassium channel blocking part is going to have reverse use dependence. Here's the caveat. Amiodarone does not exhibit reverse use dependence when it hits potassium channels. It blocks potassium channels to the same extent, regardless of whether the heart rate is fast or slow. Now, why is this important? It's important because when you have a potassium channel blocker and you're using it for an arrhythmia, usually the heart rates are pretty fast. One of the ways that you'll check safety, as we'll talk about in other lectures, is by measuring the QTC interval. But if you measure the QTC interval when the heart rate is very fast, when the heart rate then becomes slower because you've converted the arrhythmia, your QT may prolong even more and may put you in a risk range for the development of torsades due to that. Amiodarone, if you use it and it prolongs the QTC interval by 20 milliseconds, and then the heart rate goes down 30 beats per minute, it's still going to be 30 milliseconds. It does not exhibit reverse use dependence. Effective antiarrhythmic drugs on electrocardiographic intervals, what's going to impact the PR interval? The 1Cs are going to increase at some. Beta blockers will increase the PR interval due to negative dromotropic effects. The 4s will increase it due to negative dromotropic effects. The class 3s, though, it depends on what it is. Amiodarone, junetarone, and sotalol can increase the PR interval. Dofetilide doesn't impact the PR. Ibutylide doesn't impact the PR. What about the QRS complex? Okay. You don't have to know anything about the QRS complex. So let's talk about the QT, which you do have to know about. The 1As will prolong it because they block potassium channel. The 3s will block it due to effects on the potassium channel. For our purposes, you can assume that none of the others will impact the QT interval. What about some miscellaneous antiarrhythmic drugs? One of them is magnesium. Magnesium blocks L-type calcium channels, but also blocks IKR potassium channel, an effect that, by and large, helps to cancel each other out on its impact on the QT. So when you use magnesium by itself, it doesn't prolong or shorten the QT interval. However, we found that when you use magnesium with class 1A and class 3 antiarrhythmic drugs, that magnesium attenuates QTC prolongation, making torsades less likely to occur. Patients who have atrial fibrillation, patients who have monomorphic VT, when you do mouth scrapes and you send it away for intracellular diagnosis, a large percentage of them have intracellular magnesium deficiencies, even though their serum levels are normal. So here's a study that we did at Hartford Hospital. Okay? And you can see that intracellular magnesium concentration at baseline were low. 63% of people had intracellular magnesium concentrations in the deficient range, but there were no intracellular deficiencies in any of these. Serum concentrations for all of these were normal. When you replete people with magnesium, you can normalize their magnesium concentration. And what effect did it have on the QTc interval? Here are people that were receiving the drug ibutilide with sodium chloride or with magnesium sulfate. Even though magnesium by itself had no effect on the QT interval, you can see that when you use magnesium along with ibutilide, the maximum increase in the QTc was only 19 milliseconds versus 75 milliseconds with placebo. Just showing you what that looks like. Okay? For chronic therapy, instead of using IV magnesium sulfate, here we use magnesium lactate, and we showed that people who were receiving Sotalol, when they were given magnesium lactate versus placebo, actually saw a reduction in their QTc interval back toward a more normal level. What about adenosine? Adenosine is an interesting drug in that it causes a brief period of asystole. This allows, hopefully, normal pacemakers to come back and help to reestablish effects. Where does it work? It works on the AV node. So in people who have PSVT, adenosine can be used to be able to break the PSVT. And it's first-line therapy for most people with PSVT. It's not first-line therapy if you have WPW. It can increase your risk of ventricular fibrillation. But adenosine. Adenosine can be used in people with PSVT to block the reentrance circuit within the AV node and then hopefully get resolution when normal pacemakers come back online. PSVT clinical pearls. Usually the PSVT is happening due to a reentrance circuit just below the AV node. You can block that with adenosine. You can block it with non-dihydropyridine calcium channel blockers, which are usually second-line therapy for PSVT if adenosine is unsuccessful. Here you see somebody who has PSVT. You can't really see P waves. You can see the QRS complex. You can see the T waves. You can see that the rate is really, really quick. Okay? The rate is really, really fast. They gave people adenosine. They caused this period of asystole, and then things turn back to normal. Now you see P waves. Now you see QRS complexes and T waves. Okay? You see the rate is much more normal. If you have WPW, can't use any negative chromotropic drugs. We've already talked about the kind of things that you could do, one of them being to electrically convert the person right away. If you're going to use adenosine, 6 milligrams or 12 milligrams. It has an incredibly small half-life. It's broken down by plasma esterases, so you don't have to worry in hepatic disease, you don't have to worry in renal disease. But if you don't put it in and give it very rapidly, followed by a rapid push, it's not going to make it to the heart before it's all gone, and you're not going to get the pharmacologic effects of therapy. When you use adenosine, it will cause a feeling of flushing in your body. It will cause a period of asystole, and it will cause the patient to feel some chest pressure. So you want to let people know that they're going to feel chest pressure and this feeling of warmth before you get it. It'll only last for a few minutes. Antiarrhythmic drugs that can be used to terminate arrhythmias. You can see that the class 1As you can use for atrial flutter, atrial fibrillation, and monomorphic VT. The class 1Bs you can't use in any atrial tissue, so it won't work here. It will only work in monomorphic VT and torsades. The class 1Cs are very much like the class 1As. The class 2s and the class 4s can be used for PSVT. They can also be used for rate control in atrial fibrillation, but they can't be used to convert it. That's not how they work. Adenosine can be used in PSVT. Magnesium is the drug of choice for torsades. If magnesium doesn't work, the class 1Bs are alternative there. This is a slide that you'll have to know. We also have implantable cardioverter defibrillators. They have wires that are attached to the heart. They have the defibrillator here. The defibrillator looks at the heart rhythm. If it sees that there's a ventricular heart rhythm, it'll try to turn on a pacemaker and try to pace the person out of it, anti-tachycardia pacing. If that fails, it'll charge. It'll generate electricity and it'll shock the heart. And it hurts like an SOB when it shocks you, because it hurts kind of like you're shocking the person's heart with electricity. Okay? It's used in people who have a past history of ventricular fibrillation or those who have a very high risk, like they have heart failure with reduced ejection fraction. Conclusions. Pharmacists and pharmacy students taking the exam need to understand the main channel ions in pacemaker and ventricular cells in general terms. What does sodium do when the channel's open? What does calcium do? They come into the cell. What do potassium ions do? They leave the cell when the channel's open. In what phases are they most active? How ectopic foci and reentrant circuits cause arrhythmias. Know what the anatomical setup and the triggers for arrhythmias are. Very important. Know what a P wave signifies. Know what a QRS complex signifies. Know what a T wave signifies. And know where the vulnerable periods are. It's going to be very important. Know the role of the sympathetic and the parasympathetic nervous system on tachycardia, on bradycardia, and AV nodal conduction. Know the impact of class 1A, 1B, 1C, 2, 3, and 4 on automaticity, on effective refractory periods, on vulnerability to arrhythmia. Discriminate between which drugs have use versus reverse use dependence. Sodium channel blockers have use dependence. Potassium channel blockers have reverse use dependence, with the exception of amiodarone, which does not exhibit reverse use dependence. PSVT treatment options in patients with and without WPW, very important to know. And what ICDs are and what they do. That's exactly what you're going to need to know for the exam. Great. See you back here.